Ladies and gentlemen, dear colleagues, I'm very happy to share with you some data regarding the real-world burden of patients with angina undergoing angiography. These are data from a population representative study of payer claim data. My name is Professor Leistner. I'm the head of interventional cardiology at Charité University Medical Center in Berlin. Well, as you know, the prevalence and the real-world burden of angina is poorly understood, even less in patients with persistent symptoms after invasive coronary angiography. This study aimed to investigate patient characteristics and the further management of patients with persistent angina after angiography, as well as to analyze its health economic impact in a large, unselected, all-comer study cohort in Germany. We did the Florida study, which was an observational cohort study based on an anonymized, large German health claim database, including more than 4 million different data sets. Out of them, we selected a study population of 3,962 patients with coronary angiography for chronic coronary syndrome as well as for acute coronary syndrome, and follow up them for 3 years. These patients were treated initially after coronary angiography mainly by optimal medical therapy, 60%, and 40% treated by revascularization therapy, mainly by PCI. These are the results. 70% of patients had within 3 years of follow-up another angina-related rehospitalization. Importantly, this was irrespective from the initial therapeutic strategy, so this was comparable between patients initially treated by revascularization therapy as compared to patients treated by optical medical therapy. With respect to the number of physician visits per year, you see that in total, the patients had an average of 33 physician visits per year, mainly at general practitioners, but including a variety of different specialists. If you compare now the number of repeated angiography as well as of comprehensive non-invasive cardiac assessment, you see that in total, about 1/3 of patients underwent these procedures. Again, there was a slightly higher subset of patients underwent additional angiography after initial revascularization as compared to optical medical therapy, but this was without statistical significance. If you calculate the number of procedures per affected patients, you see that there was non-invasive diagnostic procedures as well as invasive procedures, and per patient there was a total of 1.5 additional angiographies in this patient cohorts. With respect to the healthcare costs per patient and year in the follow-up period, you see that the costs were more than twice as high as in the average of the German population. This means 6,663 euros per patient and year more in this patient cohort affecting by resisting angina. So let me summarize. Our study shows that angina has really a high burden in the study population and in the German populations 3 years after angiography. It includes that 70% of patients had angina-related rehospitalization. Patients had an average of 33 physician visits per year, including a variety of specialists. 1 in 4 patients underwent repeated angiography and further non-invasive diagnostics, and the resulting healthcare costs per patient per year were double compared to the average German population. This leads me to my personal conclusion that a more personalized approach seemed to be necessary for the treatment of angina to avoid the long-term burden of angina. And given the technical possibilities we have today during the angiography, it means that a complete diagnosis, including epicardial as well as microvascular diagnostics, may be appropriate to allow a more tailored and personalized therapeutic strategy against angina. Thanks for your attention.